All right, I think we can go ahead and get started. Hello, everyone. My name is Tess Killian, and I'm so happy to welcome you to the 5th Annual Cannabis in Practice webinar series, hosted by the Washtenaw County Health Department and Livingston County Health Department, in partnership with the Washtenaw County Medical Society and Livingston Physician Organization. This webinar series is aimed at addressing questions our local and regional healthcare providers have about cannabis use and their patients. Our speakers come from a wide range of backgrounds and are experts in their respective fields. Funding for this series comes from the Michigan Department of Licensing and Regulatory Affairs Cannabis Regulatory Agency. This webinar is being recorded. The webinar recording and presentation slides will be available on our website, washtenaw.org/marijuana, in the coming weeks. Before we get started, we ask that all questions for our speaker be asked through the Q&A function, which can be found at the bottom of your screen. We will have time at the end of the webinar for the speaker to answer questions. Now, I am pleased to introduce today's speaker, Dr. John Hopper. Dr. Hopper graduated from the Wayne State University School of Medicine and completed residency training in combined internal medicine and pediatrics at the University of North Carolina. Dr. Hopper was appointed to the faculty at Wayne State University School of Medicine in 1994, where he served as the founding medical director for the Department of Psychiatry's Research Division on Substance Abuse. From 2005 to 2008, he was the chief medical officer at Brighton Hospital. In 2008, Dr. Hopper joined Trinity Health and served as the program director for the Internal Medicine Residency Program and Addiction Medicine Fellowship. He currently serves as the system chair for the Department of Medicine at Trinity Health Ann Arbor and Livingston Hospitals. Dr. Hopper holds teaching appointments at Central Michigan, Georgetown, Wayne State, and the University of Michigan. Thank you so much for joining us today, Dr. Hopper. I will pull up your presentation and then we'll let you take it away.
Thanks very much, Ted. Thanks to everyone who's on the call. I'm really grateful for your interest in this topic. There's lots going on with cannabis, nationally, locally, at the state level. And I honestly think for everyone in the community, whether you're a clinician or not, adolescent cannabis is probably one of the most pressing issues for us. So in the next hour or so, we'll give you some updates from last year's presentation, and then help meet everyone where they're at in terms of what their knowledge is around cannabis and what are the pressing issues, both clinically and as well as socio-cultural, politically. Next slide. So I have no disclosures with regard to this talk, no financial relationship with industry. I'm employed by Trinity Health, IHA Medical Group. The opinions of this talk are my own, not Trinity Health. Next slide. For those who are clinicians, physicians, and APPs, if you're listening to this live presentation on August 4th at noon, you can claim CME credits. In the post-webinar survey, include your name and email address, and you get 1 hour credit through Michigan State Medical Society. Next slide. So 3 major ideas here is we're going to look at the trends in adolescent cannabis use. This is something that we've looked at the last couple of years. There is new hot data, which I think will be of great interest. Likewise, in terms of consequences of adolescent cannabis use, we're continuing to understand more about the impact on the brain development, and consequences. And then when it comes to screening and intervening, not a lot new here to present, but I'm going to review what we have discussed last year, as well as get you thinking about what's your role in adolescent cannabis use. Next slide. So as anybody who's ever heard me do a talk on adolescence knows, I like to frame our thinking with this quote. When you think back to your own adolescence, it is, for most people, the single most stressful and frightening period of human development. I think the Foster Wallace really captured it well here in terms of this yearning for both adulthood as well as the return to childish oblivion. When you think about the stressors, the difficulties adolescents face, which they have throughout time, our time is no different. Although there is a lot more social and media pressures on kids, but it's always been a difficult time. And there's a natural desire to escape the stressors, challenges, and psychoactive substances are throughout history been something adolescents and young adults have wanted to use. Next slide. And I do want to give my own personal bias right up front. In addition to thinking about adolescents, I just want to make the distinction that from my standpoint, their term medical cannabis, if you could just advance to slide 1, there's a better terminology here. In the addiction field, we refer to medical cannabis sort of jokingly, but in reality, it's voter-approved cannabis. So there are very few cannabinoid products that are available by prescription. That's the realm that, as an allopathic physician or osteopathic physician, that's the realm we live in. If you're an advanced practice person, your license probably falls under the realm of something similar. So there's only 4 FDA-approved products that have cannabinoid-like substances. They're not blockbuster drugs. Nobody's prescribing a whole lot of these drugs. Nobody's really asking for these. So the idea of medical cannabis is actually fairly limited. What we have is a system which basically allows recreational cannabis, which I think for adults is fine. But it also sort of quasi-medicalizes something that there really isn't a whole lot of evidence base for. And the idea here is that cannabis is soup. There's a lot of psychoactive chemicals in there. Some of them are beneficial. Some of them are harmful, just like in soup. You got vegetables and you got salt. Some of them are necessary for life, but too much can be a problem. The endocannabinoid system is incredibly complex. We are way behind where we need to be in terms of understanding it. And we're really throwing soup at people which mostly leads to self-medication in a way that I think ultimately makes people more likely to think that this is a safe product when we really don't know that much about it. And particularly, we don't know as much as we need to about its effect on people. So that's the bias I come to. Having said that, we're talking about adolescents today, and I think in general, there's an acceptance for people throughout society to say that developing brains should be protected from psychoactive drugs that might have an impact on the brain. So that's definitely the premise for the talk here, is that adolescents, regardless of what we think about that adult use, which again, I think is fine after the age of 25. If the brain is developing, we should try to protect it. That should be society's goal. Next slide. And a lot of my thinking is informed by the national organization Smart Approaches to Marijuana. They're not well-funded or well-known organization, but the most important thinkers, I think, in both policy as well as neurobiology and science are behind this organization, supporting and creating this organization. And it looks at a health-first approach to marijuana, which is any policies that we have as a society should look at what is the potential health impact on our society if we approve marijuana. They're not totally against marijuana per se, but they are in support of what does the evidence say. And likewise, their mission is that we don't want to create another big tobacco or big alcohol. Alcohol and tobacco are things that we can't really extricate ourselves from at this point. We're moving in the same pathway with marijuana, where again, should it be available for adults in our society? Probably, but we want to be cautious about that implementation. We should be. Next slide. So let's update you with the current trends. Next slide. As everybody in Ann Arbor knows, Monitoring the Future is one of the most important longitudinal surveys of youth in the United States. And the University of Michigan has helped us with this for many decades. So this first slide here is trends in the lifetime prevalence of marijuana use for 8th, 10th, and 12th graders. And as you might recall, during the pandemic, there was a lot of press around drops in the level of cannabis use among 8th, 10th, and 12th graders, probably partly from social isolation, difficulty in interacting with and getting drugs from peers. So we're starting to see some reversal in that trend. And I think the bottom line here is that in 2022, 12th graders, about 38%, 38.3% in this survey have reported that they had used marijuana at some point in their life. So 12th graders, 38% that's the red triangles. Next slide. And then when it comes to use in the last 12 months, so this would generally be lower level of use than we'd see in the lifetime. And for 12th graders, it's 30%. So remember, 38% have said, yes, I've tried sometime in my life. A third of them are saying, well, in the last month, I marijuana. These are 12th graders. And again, we're seeing some reversal of the data from the drop during the pandemic. You might be curious what's happening at a local level. Those of you who are interested in adolescent epidemiology and use know that Michigan conducts a survey called MyFi in the high schools. There's a limited reporting availability, but within the Washtenaw report, most recently, 11% of 11th graders reported past 30-day use. So that's between what we're seeing here in this national survey. Looks like 11th grade use might be a little bit lower than the 10th grade use nationally. So that's good news. But again, it's a limited sample of schools in Washtenaw County that participated. Next slide. And then this is a separate survey methodology, but also a very important one, the National Survey on Drug Use and Health. Monitoring the Future only looks at high school or 8th, 10th, and 12th grade. The National Survey on Drug Use and Health is a really important data set because it looks at everybody in a household age 12 and above. So we can look at nationally what's happening with that population, and then we can break it down further. So what we see here from the most recent National Survey on Drug Use and Health, no surprise, of the population who has used an illicit drug in the past year, which is almost 22% of the population 12 and older in the United States. Of the illicit drugs listed, marijuana is number one at 52 million. So the vast majority of people, if they use something, it's been marijuana. Pain reliever misuse is still pretty high, even though that has improved a lot. And hallucinogens has increased recently. So there's some important trends there. And this again is for the legal marijuana use. This has nothing with regulated or voter approved no medical marijuana, just illicit to get high. Next slide. And also from the most recent reporting period, the 2019 National Survey on Drug Use and Health. So this again would be sort of pre-pandemic. I think it's important to see where marijuana fits in terms of alcohol and cigarettes. So you can see this is people who started using in the last year. So generally this is going to be people, it says age 12 and older, but most of the time we're talking about ages 12 to 21 if it's new initiatives. It's less common for people to start using alcohol, cigarette to marijuana after the age of, say, 21 to 25. So if people are starting something new for the first time, no surprise, alcohol would be number one, and that becomes, of course, legal after the age of 21. But marijuana is a not too distant second in terms of new use. Cigarettes fortunately is much lower. It's actually kind of fascinating that cigarettes now are in the same category as pain reliever misuse. The unfortunate thing that this doesn't capture is vaping of nicotine, which, as we'll allude to, is actually another huge problem and does have an impact on cannabis use as well. So vaping is unfortunately not captured by this vaping of nicotine. Next slide. And also from national surveys. So this looks at vaping of marijuana. So for those age 12 and older who are using marijuana, how are they using it? Vaping being a much more potent way to use the drug, delivering higher brain levels and therefore having a bigger negative potential on developing brains. Unfortunately, the most vaping is occurring in the people who are most at risk for having an impact on brain development. So at 12 to 17 age, 40% of 12 to 17-year-olds using marijuana are using it by vaping primarily. And then in that next range where the brain is still developing, 18 to 25, again, it's still 27%. So this is an unfortunate statistic and something we should be thinking about in terms of policy and what should be decriminalized and what should be, perhaps sanctioned more. Next slide. And this is an old slide, and I included it, even though it's from 2015, because the numbers have held fairly steady since in pediatrics in 2015. This was the first time people looked broadly at the rates of cannabis vaping among e-cigarette users. And this was a study done in Connecticut. It was done in a number of both rural and urban schools. And, somewhere around 20-25% of high school students were vaping marijuana if they also vaped cigarettes. So fairly substantial proportion of adolescents are going to use drugs by a vaping methodology if it's available. Next slide. So that's basically it for epidemiology. If you have any questions related to epidemiology, put them in the chat, but we'll save them. Let's talk about the consequences now of use. Next slide. So, and if you could advance the slide just one, it's got some numbers on there. So, when we're thinking about adolescent use of marijuana, it is a highly prevalent substance, and most people are not going to go on to develop problems. And this is one of the challenges with everything in adolescence, whether it's cigarettes, alcohol, marijuana. Use doesn't necessarily equate with progression or the likelihood of developing disorder. Pretty much for all psychoactive substances, though, we know there's a vulnerable population. That would be people who have a family history of use, those who have greater amounts of trauma, neglect, abuse in their life, those with a greater burden from mental health problems, anxiety, depression. And these are all highly prevalent in the adolescent population. So there's a fairly recent study that we're going to look at here that looks at cannabis use based on self-report. And this is actually just a month or two old, this study from JAMA Open Network. So self-report, this is the National Survey on Drug Use and Health, which we just looked at. And they tried to tease out cannabis use versus whether it's disordered or whether there was non-disordered use. And in this study, they found that the prevalence of non-disordered use nationally in 12 to 17-year-olds, based on the 68,000 respondents in this case, was about 10.2%. So about 10% of adolescents are reporting regular non-disordered use of cannabis. And remember, in Washtenaw County, we said it's about 11% past month, so among 11th graders. And then advance the slide one more time, and we'll look at what's the disorder prevalence. So 2.5% are using cannabis in a way that's considered disorder. So let's look at this a little further on this next slide. And there's a fair amount of detail on this next slide. Again, I'm limited a little bit. You know, you might have to put on your reading glasses as did I for this one, since this is a slide that's provided by JAMA Open Network. So remember, this is National Survey on Drug Use and Health, ages 12 to 17, 69,000 respondents, it's a stratified sample, and they look at cannabis use. So, and they categorize kids into 4 categories: non-use, non-disordered, non-use, non-disordered use, and cannabis use disorder. So we got a problem. So the interesting thing in this study is that, again, how do you distinguish, disordered from non-disordered use? That has to do with the DSM criteria, which we're going to look at in a second. But even among those who are using marijuana and overtly don't seem to have a problem with their interaction with marijuana, they do have higher burdens of pretty much everything from a mental health standpoint as well as an academic and cognitive standpoint here. So greater rates of major depression, suicidal ideation, cognitive problems, including slower thinking and difficulty concentrating, truancy, lower GPA, more likely to get arrested, fights, and aggression. So it's much worse to be a disordered user, but it's not great to be using. Again, this is an association. It's not to say that the cannabis is causing these problems, but we should think about this as a marker. If somebody's using cannabis in their life in the 12 to 17 year range, they're experiencing problems probably beyond that of a peer group, a non-user peer group. So it's a really important observational set of data that I think we need to continue to look at. For the few naysayers who say, well, it's just part of growing up, it's just part of being an adolescent, which again, we'll look at from an epidemiologic standpoint here again. Next slide. So again, this was a self-reported survey. It's very difficult, and then the authors know it's hard to distinguish disordered from non-disordered use based on self-report. From a clinical standpoint, those of you who are clinicians are all familiar with the Diagnostic Statistic Manual version 5 criteria for looking at a use disorder. And a use disorder is having 2 of these symptoms, particularly looking at the big categories of continued use despite some consequences. That's a problem. Next slide. And if you do hear me use the term addiction, I'm never using it pejoratively. I'm just referring to the idea of a moderate to severe substance use disorder. So that in that problematic use or the use disorder category that we looked at earlier, about 2.5% of the population, that's what we're talking about, moderate to severe use disorder. Next slide. This is an old study, but anybody who wants further reading into the neurobiology of addiction, it's a great paper. It's actually pretty accessible even for a non-science person. Nora Volkow, the director of the National Institute on Drug Abuse, is the lead author, along with George Krug, who's probably the leading neuroscientist in addiction in the United States, and then Tom McClellan, who's probably one of the most important clinicians involved in addiction. So this is the big 3 here, and this is the final words of this paper. I think are particularly important, and that's why I put it in quotes, and that's why I'm going to read it, which is if early voluntary drug use goes undetected and unchecked, the resulting changes in the brain can ultimately erode a person's ability to control the impulse to take addictive drugs. Where does that come from? Next slide. So again, this is a graph from there that just shows what starts off reward gets tied into emotion and ultimately leads to sensitization, which becomes preoccupation and anticipation. That's the addictive component of it. So this is a really nice graphic. And when you think about the developing emotions of adolescence, it's no surprise that that's one of the reasons they're so vulnerable to psychoactive substances. Slide. And You've certainly heard me say before, there's, it's complex. We're never going to find a, single nucleotide answer to our problem with substance use, because it is this really important interplay of genes and environment. And the environment includes lots of things that adolescents are exposed to, both from parents as well as kids. And then when does the drug come in and how does it change the brain? And then just advance the slide one more time. And where is that happening in the life cycle of the brain, in the brain development process? Next slide. And you can just advance let's see, one, another, one more. So this, again, is a slide I've been using for a long time. Brain development matures from back to front. We initially start with physical coordination in the cerebellum. Motivation occurs in the nucleus accumbens. That's the toddler period. The amygdala, this is emotion, fear. This is regulating a lot of adolescent development. And the judgment part of the brain, the prefrontal cortex, really isn't myelinated fully until around 25, and it does occur a little later for males compared to females. So, primates, all primates. Next slide. So, yeah, judgment, that's the last part to develop. So, drug, it's no surprise that psychoactive drug use early on in life in the teens is going to lead to problems with development of judgment. And we've known for half a century that if people start drinking in their early teens, they're going to have a much harder time quitting than somebody who starts drinking. Next one. So here's a little new information on cannabis and brain development, along with some things that we're aware of from the past. Next slide. So Nora Volkow, again, one of my heroes, testifying at the House Committee on Energy and Commerce. I don't know how this became a cannabis policy, but anyway, I guess commerce and cannabis go together in the United States nowadays. So Nora Volkow provided testimony. One of the references she showed with this paper from the CAPRI that shows lower academic achievement, increased risk of school dropout for youth who regularly use cannabis. We've already seen more recent data that supports that from the National Household Survey. And then frequent adolescent cannabis use during adolescence is associated with brain changes in the area of motivation, attention, memory, and emotions. Nora is a neuroscientist and an imaging expert, so knows more about what's happening with the brain in substance use than anyone in the world, probably. Next slide. So this is a related paper that looks at long-term consequences of adolescent cannabinoid exposure and adult psychopathology. And this is just a quote that, again, Nora used in some testimony. Emerging evidence from human and animal studies demonstrates early onset marijuana use has long-lasting consequences on cognition. And then moreover, in humans, this is associated with a twofold increase in developing psychotic disorder. So we're going to come back to this idea of cognition in a second. Next slide. Here we are. So Jonathan Cohen at Princeton, again, brilliant neuroscientist. I like his definition of cognition. Pretty straightforward. The ability to orchestrate thought and action in accordance with internal goals. So, as any of you are clinicians know, there's most patients in your office, they're not high, they're not in withdrawal, and they recognize there's a problem, or we don't. But in any case, they know I've done things when I was high that wasn't in accordance with my internal goals, or I've done things because I'm addicted. It's not in accordance with my internal goals. So these do have an impact on cognition, and again, have an impact even in the absence of the drug once people have continued to use, creating neural changes that are difficult but not impossible to reverse. Next slide. And the thing that Again, really, because addiction is a disorder of decision making and the frontal cortex is the thing that makes you do the harder thing when it's the right thing. This is what our focus is in addiction recovery, is trying to buff up the frontal cortex, both with internal and external supports, because the natural pathway for the brain is going to be the easy routes and what gets you feeling best, fastest, which is not the same thing as what the frontal cortex wants to do. And Sapolsky, brilliant guy. You really want to understand neuro behavior at a deep level. He's got a 1,000-page book out. It's a slog, but it's fascinating and it's a good book. Next slide. So when we look at marijuana use disorders, so we think about DSM and we think about we've got at least 2 of those criteria early on. That may develop in about 30% of users. So they have at least some negative consequences from their use, about a third of people. And the risk of having a disorder is much greater in those who start before the age of 18. It should be no surprise to anyone who's been paying attention so far. Overall, about 9% of people are going to develop dependence. So that's a severe use disorder, and that's where it's very hard for them to stop on their own. That rate rises to 17% for those who started in their teens. So just the idea that a vulnerable brain is much more likely to develop a severe use problem. And when people stop cannabis, it's not just like stopping. It's very difficult because a lot of the things that you might be self-medicating for, like your mood, your sleep, your appetite, all get worse. And I think I probably mentioned before, I can think of particularly older patients, sometimes 60s, 70s, 80s, who've been using for a really long time, and for some reason they're trying to stop or they want to stop. Appetite, nausea are tremendously effective, and the withdrawal syndrome can be very difficult. And like any withdrawal syndrome, if the person is experiencing it, they know, well, if I just take one puff, I'll feel better, and that's all I need. But of course, that leads to continued use. So again, about 9% of people are going to use cannabis at a level where if they quit, they're going to have dysphoria and a difficult time stopping. Next slide. So, the environments can be helpful and healthy. It can stave off a lot of problems, or it can be a foe. I don't know if this fudge has cannabis in it or not, but part of the reason we have so much obesity in the United States is that we have ready access to calorically dense foods that our brain loves. And unfortunately, that's what a lot of the cannabis business is all about, is giving people what the brain loves, making it really easy to get. Next slide. So this slide is not updated from last year. It's not something that the DEA regularly publishes, but we have seen a rise in the content of the tetrahydrocannabidiol content of marijuana seized by the Drug Enforcement Administration. Now, it doesn't look like much, 10 to 14%, but next slide. If we go back and look over time, we see there's this inverse relationship between youth, their use, and their perceived risk. So we're actually not anywhere near the peak of use of marijuana in the United States right now, which occurred back in the early 80s. So use really peaked here. They show about 78, somewhere around there, but that late 70s, early 80s, that's when the use of marijuana was at its peak in the United States. At that time, perceived risk was very low. So we can see here the negative trend is that right now perceived risk is also perceived as very low. The difference between 1980 and 2020 is the content of THC is much, much higher nowadays. So there's probably just a few percentage THC of marijuana back in the 70s. Now we have a much more potent drug out there. And THC, of course, is the psychoactive component, not the CBD of marijuana. So it's frightening in terms of what might the impact of this be on the brain, given this the potency of this. Next slide. So this paper, it's hard for me to believe it's almost 10 years old now, and we still don't have much more information on this in terms of adverse health effects of marijuana. There was a white paper done by the Academy of Medicine on this. It's a little more recent, but it doesn't really provide any much more dramatic information. So I do think this is a very reliable source that you can go to if you say, well, what are the potential consequences here? Next slide. And so this shows you effects on short-term use and effects on long-term or heavy use of marijuana. And they have several little asterisks here where it says this effect is strongly associated with initial marijuana use in early adolescence. So that includes addiction, altered brain development, poor educational outcome, cognitive impairment, diminished life satisfaction and achievement, determined on the basis of subjective and objective measures. Sounds bad, sounds like you need to make sure adolescents don't get exposed to long-term or heavy use. And of course, with short-term use, we can see, people can use for the first time and die because of car accidents. They can get involved in trauma, adverse sexual behavior, and then psychosis and paranoia certainly occurs with exposure, and even people who haven't had prior psychosis. Next slide. And again, genetics plays a role. There's certainly greater susceptibility in some individuals. What percentage of the susceptibility is accounted for by genetics? There's limited data in terms of trend studies. It's less than 50%, but that's usually the case for most genetic studies. Next slide. Now, there are a couple of genetic variants that are important here, which have to do with the overall depression, mood, and that's ATK and COMT. And marijuana use is associated with greater risk of psychosis, anxiety, depression. Greater potency products probably increase the risk. And then those who are using marijuana are at greater risk for misusing alcohol, nicotine, and other drugs. So this is another major problem with adolescent cannabis use that we should be aware of. Next slide. And on that note, again, this is a slide, almost 10 years old now, but it's still not as well recognized as it should be, that nicotine is a gateway drug, and that exposure of the adolescent brain to nicotine makes one more susceptible to stimulant use disorders, so drugs like cocaine, methamphetamine, as well as stimulants like Adderall, ADHD meds. So part of the reason for our uptick now in the United States of stimulant use problems is because we had too much nicotine exposure to developing brains because of the ready availability of products like Juul and other vaping things that have been targeting adolescents. Cigarette companies aren't going after adolescents anymore, but the nicotine companies are going after them, and it's the same companies. It just making it look different for a new generation. Next slide. So in the last 15 minutes or so, let's just review where are we at in terms of screening and intervention. If you're involved with adolescents and do screening, the CRAFT is the single most important and validated tool, and it's on the next slide here. John Knight, Boston, developed this. The CRAFT, even adolescent says, yeah, I don't drink, I don't do drugs, I don't smoke. You're still going to ask them the C question. Have you ever ridden in a car driven by someone who is high or using? Unfortunately, a lot of times the answer is yes, and it might be a parent, in which case the intervention becomes much more complicated. And then the other questions are asked for adolescents who have used, whether you can use this for alcohol or other substances, but mostly we're using it for marijuana. You ever use to relax, alone, you ever use it to forget, family and friends tell you to cut down, have you ever got in trouble? The nice thing about this is a screening tool is it can be done online, it can be done on paper, it can be done in an interview, but no matter what, you get some idea of what's going on from a context standpoint, a contextual use. It's not just a simple quantity and frequency thing, but it also tells you a little bit that might help you with making a house bad is this diagnosis and how much treatment. Next slide. So this is just from one of the Crafts papers. You can see how it's done in interview format. And again, adolescents do very well with this and even if they know you're going to read it, give it to them on a computer. The reporting rate is probably higher than the next slide. And then this is a model that I like. It's a quick model. You have limited exposure to working with adolescents, and you're thinking about how do I briefly intervene with this population. The Warren model is the one that we teach, and the next slide here. And this is a pretty prototypic. It's a real case, but it's a prototypic case. A 14-year-old high school student wants to get off prescription drugs. She's using opioids and stimulants. She doesn't smoke. She occasionally uses marijuana. She uses cannabis every day. Tells you it's not a problem. Can't understand why you might want to address cannabis with her as well as the opioids and stimulants. Next slide. And in this model, again, it's based on Prochaska Di Clementi's transtheoretical model of change. It's designed to be used longitudinally in that we're going to identify, hey, so marijuana is not a problem. I understand. Is there any way you can imagine that life has a problem in your life? Sure, there's nothing that is causing the problem. Just sort of curious, non-judgmental question. And then, the question that allows for the space to create cognitive dissonance. Do you think there'd be anything that would be better about your life if you stopped using marijuana or whatever? Again, you're going to use the language of the adolescents using. And pause. This is a really important time for the clinical pause, and you might get a superficial answer and can reflect that back and let them think a little bit more. And then what would be hard? And then you could even put them in a situation, a little bit about the context of their use. Yeah, I always smoke before football games on Saturday. All right, well, let's say you were with your friends and you normally would be smoking and you wanted to not smoke. How hard would that be? What would be hard about it? Again, this allows you to create cognitive dissonance without creating any conflict between you and the adolescent. And then, again, just 2 or 3 questions, you get sort of an idea more about context and what are the advantages and disadvantages. You might get an idea how problematic is this? Do we need referral? Or is this something which is the majority of the time that we can say, well, here's where you're at. Is it okay if we continue to talk about this? I want you to know that I don't think it's great for you from a health standpoint and from the brain standpoint that you're using marijuana, but I want us to be able to talk about it. And next time we'll look at what's going on, and I want you to be comfortable to tell me that you feel like one of these problems is occurring. We might need some help. And it's well received. And again, I think from a longitudinal standpoint, it's a great way to engage in the conversation, but also make it clear that I don't think this is good from a health standpoint. You don't want the adolescent walking away saying, well, yeah, the doctor talked about marijuana, or the provider talked about marijuana. He said, yeah, it's okay. It's not, it should never be the message. Okay, next slide. So principles of adolescent substance abuse treatment, and NIDA has a research guide. It's very old, but it's still quite relevant. Next slide. And these are the treatment principles, and I want to highlight number 8, families and community are important aspects of treatment. Probably actually the most important thing for adults and children. But it's particularly important with adolescents because a lot of times when adolescents are coming into the office or setting, they're maybe not there voluntarily, maybe their family's involved. And there is a tendency, a strong tendency, and this happens with adults too, where the family brings in the person and says, fix them and then send them back to me. But of course, their use occurs in the context of the family, and particularly for adolescents, families have to be engaged in the treatment. If they're not, there is limited chance of success. And this is really hard for families. It's hard cognitively for them to believe that this is true. It's hard for them to find therapy if they want to do it. It's hard for them to fit it into their lives. It's hard to get families on the same page. A lot of times that's a big problem, is there's conflict between different parental sources in the family. So, but it's one of the most important aspects of adolescent treatment. Next slide. So prevention. Of course, my goal would be to have a society where nobody gets exposed to cannabis before the age of 25. I don't think that's going to happen anytime soon. Next slide. This is the research-based guide from NIDA. It's 20 years old, but it still stands the test of time in terms of what has been shown to benefit. And I think the idea here is that we need sort of a universal societal approach, that it's not good for kids to be using psychoactive substances, and then targeted interventions for at-risk populations. And guess what? This has been done. Next slide. Again, I have no new data from last year, but Iceland is still the world's model for a preventative approach. And they were, literally sort of the joke of Europe in terms of all of Western Europe. The highest rates of tobacco use, the highest rates of adolescent drinking occurred in Iceland. And they sort of took some degree of pride in that. This is how we live here, and this is how we were raised. But the problems were not evenly distributed. This was not an equitable issue. It was more in kids who had more social isolation, less parental involvement. So it's a small country, less than 500,000 people. There's a lot of homogeneity, a lot of people are related. And they decided, hey, we need to make a change. This is not good for us as a society. So through a combination of multiple efforts that included basically getting everybody on the same page, is like, yeah, we shouldn't let young kids under 16 be drinking and smoking all afternoon when they get home from school and it's the middle of the winter and it's dark and there's nothing else to do. Yes, that's what we did. We need to do something else. So they basically created avenues for engagement for pretty much anything that kids were interested in: sports, music, art, and they particularly put the resources into the highest risk population. So guess what? Next slide, no surprise. They had a huge impact. They went from the highest rates of alcohol and tobacco use in Europe to the lowest rates. And they're the model. We still are. So this, by 2007, was a 10-year effort. They have maintained this relatively low level. Next slide. So again, I think for us, the adults in the room here, we have to recognize with great sensitivity, this is a really vulnerable population, and what has gone on in the past is not okay. And that we really need to be thinking about these kids not as market sources for future profit, which is basically how they're treated by cannabis, nicotine companies. But this is our future. Next slide. So again, just to bring it home, there's a strong association that if you did or didn't use cannabis use, you're more likely to have problems as a result with employment and quality of life. But when we adjust for behavioral comorbidities, maybe it's not as big an issue. Again, cannabis use disorder, just like Iceland here, it's these at-risk youth that we need to intervene on. If you're using cannabis, there's probably some bigger problems than the cannabis use that need to be addressed. Next slide. So along those lines, anything that protects the developing brain and helps the development of young brains, so early childhood education, pre-K, tremendously important. Being able to read well by third grade should be a societal goal because that actually is the best predictor of health outcomes. I'll get in touch with the Children's Literacy Network, which is based in Ann Arbor, which is that was their goal, and we really try to work with organizations in the community to get kids reading. So if you're looking, what can I do? Read about Children's Literacy Network. Get involved with them. Early education and wellness. So really thinking about wellness from the standpoint of not what's on Instagram and TikTok and Twitch and being an influencer. That none of that will sustain you in the long run. So supporting sober environments. You know, we don't do a very good job of this in Ann Arbor. We have so much marketing. We have so much permissiveness. You know, as much as I, as an adult, like the atmosphere in Ann Arbor, it's a little troubling when they close off the roads and say, this is, you know, the zone where you can take your alcohol out of the establishment and walk around on the street. Well, if it was an adults only zone, that might be okay, but it does increase the likelihood that people think, yeah, this is not a problem. Drinking is just part of being an adult. So supporting mental health, substance treatment, and then decriminalization. So then drug use is not a crime. It shouldn't never have been a crime. And it's something we need to take out of the justice system and really bring back into the public health as well as community health as well. Next slide. And in terms of resources, next slide, Washtenaw County, these links, I checked them out, they work. Washtenaw has some good information on marijuana as there's National Institute on Drug Abuse. This is one of their fast facts, very useful. We got time for questions here. Next slide. No. And I know we won't get to all the questions, so you can actually even advance to the next slide, which has email address on there. Oh, this is, yeah, a reminder of the CME. So at the end of this, there's a post-webinar survey. Definitely want your feedback and put your name and email address and if you want this stuff. Right, and there is my email if you don't have time to get your questions answered. Tess will have to queue me up in terms of what questions I should address. If they're in the chat, I will see them. But
Yes, absolutely. Thank you so much, Dr. Hopper, for that fabulous presentation. We do have a couple of questions that have come through. And before we start them, just a reminder to please put your questions in the Q&A function, which can be found at the bottom of your screen. And the webinar recording and presentation slides will be available on our website, washtenaw.org/marijuana in the coming weeks. All right, so for our first question is, are you a member of IASIC, which if you're not familiar with that acronym, it's International Academy on the Science and Impact of Cannabis?
yeah, I'm not familiar with it, and I'll have to look into it.
Thank you. And then the next question is, which organizations in our community can we refer young people or adults for a brief intervention regarding marijuana use? U of M has the Alcohol Management Program for risk reduction and or abstinence support. Is there a program like this for cannabis?
Yeah, I'm not familiar with anything that's specific for cannabis. So again, the treatment services are going to University of Michigan Addiction Treatment Services, Recovery Medicine, which is Trinity Health IHA. I think specifically for adolescents, Ozone House along with Corner Health do have services. that again are mostly referred out, but options are really, 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 really one of the great challenges.
Another question that I have is, how has the increased potency of THC affected the development of the young brain?
Yeah, again, the specifics are not well understood because we don't understand as much about the cannabinoid system as we'd like, but specifically the hippocampus, which helps with processing memory, is clearly affected by cannabis. Likewise, there is impact on the emotional centers, amygdala, and in terms of its cognitive effect, it's probably the area where we understand more.
Right, so we have a few more minutes and a couple more questions. We'll try to get to as many as we can. The next one is, how can we get the mental health community to address marijuana specifically? In San Diego County, 40% of suicides have marijuana in their system.
Yeah, I think it's very challenging because once someone has reached adulthood and it's past the age of 25, it's very, very difficult to get them to recognize or change. So I do think really having a singular focus on adolescence where we can all agree, if we get the mental health community to agree that this, whether you think it changes the brain or not, it's clearly a marker for problems, and we really need to unite around it from an adolescent standpoint. I do think addressing an adult is a much, not that first problem is hard enough. It's going to be even harder with adults.
Right. This next and probably final question for the time. It's, thanks, Dr. Hopper. What is the best strategy for screening for marijuana use? Is there a single or multiple questionnaires like Audit C for alcohol, etc.? Thanks. Great presentation.
So there's nothing that's been validated as a best approach. NIDA does have a screening process, but I do find it's a little cumbersome. I think the best thing to do is, again, when you're talking to adolescents, you always want to start with what's happening in the environment first. So tell me about your school. Are there kids within your school, not necessarily even your friends, who are using alcohol, marijuana, or other drugs? And if the answer is no to that, that's great. How about in your family or for your own self? But I think in terms of a screening tool, NIDA does have one. I believe it's called the Assist. I think it's a little complicated, but that's the only thing that has any validation behind it. But it's fairly labor intensive, unfortunately. All right, to see Stephanie from Ozone House put her information in the chat. So thank you.
Yes, absolutely. Well, and with that, we will conclude our webinar series. So thank you so much for the presentation today, Dr. Hopper, and for all of our speakers. And thank you, our audience members, for attending.